great to be a part of this panel for it and to give our opening prayer. I'm going to take our opening prayer from the Book of Common Prayer and the prayer for the human family, because it is our job as Christians to not only work for the well-being of other Christians, but for the entirety of the human family. So let us pray. O God, you made us in your own image and redeemed us through Jesus, your Son. Look with compassion on the whole human family. Take away the arrogance and hatred which infect our hearts. Break down the walls that separate us. Unite us in bonds of love and work through our struggle and confusion to accomplish your purposes on earth. That in your good time, all nations and races may serve you in harmony around your heavenly throne. Through Jesus Christ, our Lord. Amen. And it's my pleasure now to introduce to you Mary Kate Wold, the CEO and president of the Church Pension Fund and a member of our board of trustees. I have had the pleasure of working directly with Mary Kate for many years, and she brings a very long history of working in the Department of the Treasury, also with in finance and legal and also healthcare industry. And she comes to us, and she is one of those people that you see around the church that is driven by purpose and mission for the betterment, not only of the church, but of the world. And I am glad that I work with her as she fulfills that mission and purpose in her life here at the Church Pension Fund. Mary Kate, over to you.
Thank you, Clayton. I wasn't expecting all of that, but thank you. I'm really thrilled that you all are here. This is our second quarter Insights and Ideas event, and this is one of a multi-year series of events we've been hosting called Insights and Ideas, focused on socially responsible investing. And that's an area that's very important to us at the Pension Fund. We have what we believe is a very powerful four-pronged strategy for socially responsible investing. The first prong is impact investing, which is making the returns that we believe we need to make, seeking those returns, while at the same time doing good. And we'll have an example of that when we talk to one of our panelists today, one of the who represents one of the firms with whom we invest. The second area is shareholder engagement, and here we collaborate closely with the Committee on Corporate Responsibility, Social Responsibility of the Executive Council, and that means engaging public companies that are in our portfolio and encouraging to act in ways that are consistent with the values of the Episcopal Church. The third prong is what we call ESG incorporation, and that means whenever we're looking at new investments, we consider ESG criteria as relevant to our due diligence, and that allows us, again, to live in a manner that's consistent with the values of the Episcopal Church. And then the last prong, which is very important to us, is what we call thought leadership. And that means us encouraging others to join us in this space of doing good while we do well in the world, and also to bring experts to the church who can talk to these issues of socially responsible investing and hopefully inspire others to join us. So this is one of those events today. And today we're going to be talking about the social determinants of health. And we know that there are many things in the U.S. Healthcare system that are broken. We spend more money than most, if not all, other developed countries in the world. And yes, yet on many markers of health, we actually lag behind. Are we spending money where we need to be spending it? What could we do better to enhance health outcomes? How are racial and economic disparities impacting health outcomes in the United States? And also, what can we do at the Church Pension Fund, and what can you all do to address some of these disparities and issues that we find in the healthcare system? So I have two people who are going to help us answer those and many other questions that relate to social determinants of health. And those are Dr. Ann Barnes and Dr. Leonard Fromer. So I'll just say a little bit about each of them, but you have their biographies in the chat. They are both very impressive individuals, and it's going to be a treat to hear from them today. So first of all, a few things about Dr. Ann Barnes. She is the president and CEO of the Episcopal Health Foundation, and that foundation serves the 80 counties of the Episcopal Church in the Diocese of Texas, and it's committed to the promotion of health equity. Dr. Barnes is also an associate professor of medicine at Baylor College of Medicine. She also holds an adjunct faculty position at the University of Houston College of Medicine. Her prior roles have included executive positions in large safety net healthcare systems. And then turning to Dr. Len Fromer. Dr. Fromer is the president of healthcare initiatives at Turner Impact Capital. And Turner Impact Capital is an asset manager with whom we invest at the Church Pension Fund. It's one of the nation's largest and fastest growing social impact investment firms. And they invest in real estate solutions that address daunting societal challenges across the United States. Dr. Fromer is a nationally recognized expert in areas of primary care, practice redesign, and transformation. And he was a practicing physician for over 28 years. So you have two individuals who are actually practicing physicians, but operating in this world of investments and policy changes. So let me, and I'm sorry, also have to introduce our own Christopher Rowe. So Christopher is a managing director in our investment group here at the Church Pension Fund. And one of his areas of responsibility is advancing our socially responsible investing efforts. Prior to joining the Church Pension Fund, Christopher had more than 25 years in the asset management industry, where he worked with clients on aligning their values with finance. So I'm going to jump in and ask a few questions, but I think first it would be good to get a grounding. What do we mean by social determinants of health? And Anne, I thought I'd start with you. Can you give us a little bit of background by what we mean by that term and why it's important to this conversation?
Yes, I'd be happy to, Mary Kate, and it's really a pleasure for me to be here with you all today. So when we talk about social determinants of health or non-medical drivers of health, there are a lot of ways that we could approach that. One way that I like to think about it is if you look at your own life and think about how much time you spend in a hospital or clinic each year, you'll realize it's a very, very small amount. Well, all the rest of your life is outside of the clinical setting, and it is in that out of clinic time that we all really experience health. And so there are a variety of things in our environment that can promote our health, hinder our health, or harm our health. And some categories of those social determinants of health include housing, access to healthy food, transportation to get around, employment status, socioeconomic status, and connection to a social network, family and friends who you are a part of. And all of these factors in turn can impact the behaviors or health behaviors that you might choose to do. And that would include alcohol consumption, being physically active, eating healthy foods, and smoking. And so when we talk about social determinants of health, we're talking about all of those factors in your environment that impact your health outside of the clinical setting. And we believe, and research supports, that 80% of our health are determined by those social factors.
That's huge. That's a surprising number.
Indeed.
Thank you. And Len, could you talk to us a little bit about, I made the comment actually that we in the United States spend more money than most other, if not all, developed countries on healthcare, and yet we're not showing great numbers on a number of measures. Can you tell us what's going on there? Can you elaborate a bit?
Oh, happy to. First, let me say thank you for having me. It's a pleasure to see everyone and be here with you today. I loved Anne's answer about the social determinants, because it actually directly relates to how much do we spend and what do we get for the money we spend in our somewhat dysfunctional American healthcare system. One thing I would add to what Ann said, just to amplify it, there's a really nice saying we have here in Los Angeles on the West Coast that was put out by the California Endowment that really sums it up well. And it says, the saying is, health happens at home, health happens at school, health happens in the workplace, health happens in the community. It's all around us. And it is not only, and especially when you look at the ratio where it happens, it's not in the healthcare facilities only. That's the minority of where it happens. It happens in the real world, out where people live, work, play, and go to school. So in America, we spend twice as much per person for the healthcare that we get in our system, twice as much per person than the next nearest industrialized country in the world. It's one of the Scandinavian countries. I believe it might be Norway, but not relevant to what the meaning of the question and answer is. We're going on about 18% of our gross national product yearly that gets spent on healthcare. We're over $4 trillion in total. That is about equivalent to the entire economy of Germany. And we spend that on healthcare. What do we get for that? We get, unfortunately, below average results on most very legitimate surveys of what outcomes patients get, what experience they have in the healthcare system, and equity issues, cost of the population health that we drive from that, people's health, wellness, and longevity. We get below average results among the industrialized nations of the world. So the problem is big, it's huge, and it needs really big solutions to that on a issue about scaling the solutions. I think you mentioned it, Mary Kate, in the beginning about how do we approach these daunting challenges and put together philanthropy, put together government granting, put together that with private market-driven results and trying to scale those solutions.
So listening to you, you're both very successful physicians and probably accustomed to being in the clinic and finding problems that you can actually solve. What's tempted each of you to kind of emerge from that and look at these big, daunting issues that affect healthcare?
Yeah, I'll let Ann speak first because my answer could take an hour.
Well, I'll cut you off, but
Good. Please do.
Thank you, Lynn. And I think the truth of the matter is that we came to the realization that there is so much more to be done outside of the clinical setting. I think we both came to that realization in similar ways. So, you know, I practiced medicine for many years and learned very early on that just writing prescriptions for individuals was not going to change their health. People came in with the same constellation of conditions: diabetes, obesity, high blood pressure. I would make recommendations on living a healthy life. I would write prescriptions, and then they would come back to see me with the same conditions, and nothing had changed. And so I really started listening to them about what was going on in their lives outside of the clinic, what kind of environments they were living in, what they had access to and what they didn't have access to. And then it occurred to me that if I really wanted to impact health, and that's what I took an oath to do, that I had to look for opportunities to collaborate with other folks on interventions outside of the clinical setting. That really began to address those social determinants of health. So I've really had the privilege over my career to participate in collaboratives with like-minded folks to begin to change environments so that they promote health. And had the opportunity after many years in safety net healthcare systems to step into this role at Episcopal Health Foundation. I get to work in the same space and around the same issues I always have, with the luxury of having some resources to bring to bear on really making a change and transforming health in our state and in our country.
Terrific. Len, the Cliff Notes
Yeah.
version.
Okay, the Cliff Notes version. Well, to put it quickly, my story goes back to when I was practicing as a family physician here in LA, seeing, I'd say 75% of our patients were safety net patients, and going home every night feeling frustrated that we weren't making a difference. Like Anne, we were writing prescriptions, we were putting Band-Aids on serious problems that people had, but not solving the problem, not getting upstream. And why is this happening in the first place? So the frustration and burnout that caused in all of us, all the doctors, physician assistants, nurse practitioners, the teams that supported us, everybody feeling frustrated that we really weren't getting at the root of the problem, which was what happened to the folks we were seeing in the office when they went home, when they left the office, when they lived in the real world, and the social challenges around that. At the same time, I was teaching in two settings, and one of them involved working with a man who was my mentor all along, but he also, at the age of 73, after a lifetime of taking care of people in his primary care office, decided to start a family medicine residency training program. And that's the one I went through in my training. At his retirement, about 5 years later, when the program was up and running and everything was moving along, graduating doctors every year that would go out and practice community-facing primary care, someone asked him at his retirement, why did you decide to do this in your 70s? You had a lifetime of great accomplishment, well-known, national, well-known doctor. And he chuckled a little bit and he said, well, it took him 70 years to figure out that as a physician with a white coat on, seeing people in an office, you could help maybe 25, 30 people a day. But if you could multiply that exponentially by training other people to see 25 and 30 people a day, and the impact they had on the patients they saw, that has stuck with me for the last 30 years. And I will never forget that. And as I went home every night frustrated so much about what we were doing and things we couldn't make a difference in, started to get involved in leadership in our National Primary Care Academy, Family Medicine, American Academy of Family Physicians, and ultimately was connected to the folks you're going to hear about as we talk more today at Turner Impact Capital, and their crazy idea of using private equity money, capital that could empower community-facing healthcare where it wasn't existing, where people did not have good access, that people did not have the ability to get quality healthcare, and do it in a way that we would build to suit facilities that empowered them to go upstream and practice what we call value-based preventative care and still be great at rescuing sick people. So as the story unfolds today, we'll hear more about how that happened, but that was my path to how I ended up in the position I'm in now.
Terrific. Well, that's a nice segue, because I want to ask you both about your organizations and to give our audience a little more detail about what each of your organizations does. So Len, why don't we start with you, since you started down that path, and tell us a little bit about Turner Impact Capital, please.
Sure, happy to. So our company, Turner Impact Capital, has three interrelated funds that invest in building facilities or owning and operating facilities to address the challenges of quality education, affordable healthcare, and access to healthcare, and affordable housing. And those funds have a model of how we operate, where we raise money from investors, we pool that money, we take that money, and then we provide up to 100% of the capital. In the case of my healthcare fund, 100% of the capital needed to build and develop infrastructure in underserved communities. In our case, healthcare facilities, which would include federally qualified community health centers, Medicare Advantage centers for the frail elderly, the PACE program of all-inclusive care for the elderly, medical respite facilities, and behavioral health facilities in locations where people struggle to get access to quality care. We provide that capital in exchange for a long-term lease that they sign, the clinical partner who delivers the care, our clinical partners in those facilities. And we become the landlord and they become the tenant in this long-term relationship to be in those facilities and provide the services that lead to great, what we call quadruple aim outcomes, great patient outcomes with their problems and addressing their problems, great patient experience in the care process, lower total population costs, so it's affordable for everyone, and an experience that doesn't burn out the healthcare teams. That's the quadruple aim, those 4 items. And we sit essentially at the intersection of doing financial diligence on every project we do so that we know it's economically feasible and sustainable, and doing clinical diligence so that we know that the care that's going to be offered in that facility is top-notch, doing great preventative care as we also rescue sick people when they need it, and collecting key performance indicators that prove that we're making an impact on those social challenges, improving the health of the communities by improving the health, wellness, and longevity of each patient.
That sounds great. And that's oftentimes tricky in this world of socially responsible investing. It's easier to determine whether an investment is financially successful than it is to determine whether it's actually meeting its social objectives. So that sounds fascinating. Well, thank you. Anne, could you tell us about the history of the Episcopal Health Foundation and what your organization does?
Yes, I'd be happy to. So we are what is considered a conversion foundation. So about 9 years ago, the Episcopal Diocese of Texas decided to sell St. Luke's Hospital, which was in the Houston area, to another hospital entity. And a part of that transaction was $1 billion to be set aside to establish a health foundation. So the diocese didn't want to get out of health, just out of health care at the time. And so the $1 billion was invested, and we are able to do programming from the interest that we get from that very large corpus. And so we really look at investing in the communities across the diocese in 3 ways. One is traditional grant making. So individuals will submit an application about a way in which they're going to improve the health in the diocese, and we would give them funds to do that work. Another thing that we do, which is really unique in the philanthropic space, is we engage congregations and community collaboratives in capacity building on how best to set collective goals, work together, and from the ground up, transform health in their communities. And then the last arm or the last leg in our 3-legged stool is research, innovation, and evaluation. So we partner with different entities across the country to do research that can help inform decision makers about what's important to Texans and also what areas would benefit from some focus in terms of improving the health of the community. And so that's the work that we do using our investments to really create healthy communities for all.
Thank you. That's terrific. And Christopher, I don't want to leave you out. Do you want to talk about what we do here at the Church Pension Fund in this space?
Certainly glad to do that and glad to be part of this conversation, certainly inspired by the work of Dr. Barnes and Dr. Fromer. So at the Church Pension Fund, of course, our mission here is to manage the investment portfolio in a way that will generate the returns needed to pay pension benefits to our beneficiaries. And so that is a focus that we use as our North Star to a lot of the work that we do. We're also deeply mindful of the constituents that we serve, our beneficiaries. We are part of a faith-based community, and we believe strongly that we should be focused also on the values of the church and how do we support the values of the church in the context of the investments that we make. So on the impact investing side, which is one of the 4 parts to our socially responsible investing program. It's important to note that we as a investment team invest through managers like Turner Impact. We don't make direct investments in companies. We don't make direct investments in buildings. But what we do is to focus strongly on which are the firms out there that are able to generate those returns that are needed and also have a positive social impact. And Turner is a marvelous example. So we are invested in two of their funds. We're invested in their housing fund, and we're invested in their healthcare fund. And we believe strongly that this is part of our mission as an investment team to identify those opportunities that really have a strong positive social impact while also generating returns. On the impact investing side, also, in addition to issues like housing, healthcare, we're very much recently focused on climate. Climate has been a key concern of the investment team, and we're finding interesting ways to invest into climate solutions as well. But that's just a snapshot of what we do as a team.
Thank you. Well, I think it would be helpful to get a little more granular. So, Anne, could you talk to a particular grant that you've made, or one or two grants you've made that have been impactful, and give us a little more detail?
Yeah, I'd be happy to. So a few years back, Episcopal Health Foundation partnered with a community clinic around their asthma population. So we gave them money to, in addition to doing clinical care, children would come in with an asthma flare, they would write prescriptions, they would create an action plan, and then they would send the kids home. Well, they noticed that kids kept coming back over and over, despite doing all the right things. And so they came to Episcopal Health Foundation asking for money to initiate a home visiting program for their children with asthma. And so through the home visiting program, and we have a great story on our website, one child in particular, they went to the home, they identified old carpet, they identified that he was sleeping on a very old mattress, and also that there was significant mold in the apartment in which he was staying. So no matter how much medicine he got in the clinic, he would go back to that environment and it would trigger another attack. And so the money that we gave to them to do the home visiting program also gave them the opportunity to seek remediation strategies to improve the conditions in which the child lived. And remarkably, but not surprisingly, the asthma flares stopped. And I think that's just a great example about how going upstream from just clinical care, going into the environment in which the child and his family lived, was so crucial in actually improving his health outcome. And I think that's probably one of the strongest examples I can share.
That's a terrific example. Thank you. That's wonderful. Len, what about you? Can you talk to a specific investment?
Sure. Thank you. We've done 34 investments on our first iteration of our healthcare fund. We're now working in fund number 2 and continuing to build and develop new facilities and projects. One of the ones in fund 1 that I'd love to focus on is one of my favorites. We love them all. They've all made an impact on the lives of, I think in total in fund 1, 120,000 patients in those facilities. But one we did that was in the Inland Empire here in Southern California had to do with a very qualified community health center that wanted to open its own PACE program. It was the first PACE center that they would have. They're now expanding into their second and so forth. But their first one, and the reason they wanted to do this was after years of operating as a community health center serving all ages, they realized and noticed that they were losing their patients after they aged into Medicare eligibility at age 65. And pretty much, I would say probably 100% of the patients in the age group that was Medicare and Medicaid eligible were dual eligible patients and covered by both the Medicare and Medicaid program when they aged into it. They wanted to stop that out migration of the patients. So they landed on a solution to that being the development of a PACE program And then in the same building, it turned out that we found for them on the second floor, have a brand new community health center. So they would have both going on at the same time every day. The seniors in the PACE program, it's been phenomenally successful in the almost 3 years now that it's been open. And in the community health center, they've had rapid growth to fill that. I think they have something like 10,000 patients already. The key indicator of making an impact in people's lives, and why I love this program so much, when we collect our annual statistics around how did they do with impacting the lives of the patients they see, when they got the result to send to us, which comes in, it lags about 3 months from the end of the calendar year. So it was in March. The CEO had to pick up the phone and call me the very minute he got the result because he was so excited, and they didn't even know it until they actually looked at the statistics. 100% of the patients who were taken care of in those 2 parts of this one facility that we built for them, 100% of the people who ended up needing to be into the hospital at some point in that calendar year, last calendar year, 2022, after they were discharged from the hospital, not one single person ended up being readmitted within 30 days. It's a statistic that's a national benchmark of excellence, 30-day all-cause readmission to the hospital. They had 0 patients get readmitted because of the quality of care and access that they were offering in that facility that we built for them. So extremely proud of that statistic. They were very, very excited once they realized that. Just an amazing result. There's so many more I can talk about where involving the much more impactful prevention of the downstream catastrophes from COVID that happened in the last 3 years that we were able to achieve with our partner clinical organizations, reducing the risk that patients got COVID, and then providing care if they did get it that helped them survive and reduce the mortality rate dramatically compared to the rest of the country. So very excited about that, those kinds of impact statistics.
Well, thank you both. Those are such excellent examples of what's possible. So this is very, very, very exciting and made it very tangible.
Mary Kate, may I jump in here? And
absolutely.
We have a few questions that are popping up in the Q&A, and I'm very grateful that the audience is engaged here. And maybe we can use this as an opportunity to respond because, Len, what you just were saying, there are a couple questions related. One is, could you remind people what the PACE program is? And then second, to either one of you, Len or Ann, there's a question from somebody who's 80 years old and living in a life care community. Could you speak to some of the specific issues to older adults in terms of the social determinants of health? And in particular, she referenced social isolation as one issue that older adults experience.
Yeah, thanks, Christopher. Appreciate that. PACE stands for Program of All-Inclusive Care for the Elderly. It's a combined federal state program funded by taxpayer dollars for about 95% of the patients who are PACE members across the country. It's been around for, believe it or not, about, I'd say 60 years. Got started in kind of a test beta form back in the 1960s and 70s. And it is essentially for patients who are frail elderly who would otherwise need a nursing home to live in if they did not have access to the PACE centers that we and other people build for these clinical programs that operate in those centers. The key element of it that makes it so distinctful compared to the rest of our country system are different. I don't know if distinctful is a word, but the key element that makes it unique is that it's a 100% value-based payment to the PACE program operators. The clinical teams that take care of the patients get paid a per member per month fixed amount of money by the combined Medicare and Medicaid programs. And rather than get a fee every time they see the patient, within that budget they have to provide 100% of what the patient needs in everything they need for their health care. If that PACE program clinical operator, clinical team decides the patient needs transportation, they have to provide transportation for the patient to get to and from their visits, to go to other specialists, to go to other doctors, to go to the hospital. And when COVID hit, I will tell you, every very high quality PACE operators, which are the ones we work with, they all decided that they had to go shopping for the patient and keep them away from the virus so they could stay in their own home and not get COVID. And they went ahead and did that. Talk about social determinants. That was job one. It was one program we worked with that within 72 hours had in the hands of every one of their patients and the families of those patients modified iPad tablets so that they could take care of the patient virtually, provide for the issue of isolation by contacting every patient every day, rain or shine, no matter what was going on, by the healthcare team. So PACE is a comprehensive capitated program, meaning it's a per member per month fixed amount of money that provides care for everything the patient needs and gets scrutinized very much in a good sense in looking at how do they perform on that quadruple aim I mentioned and get those great patient outcomes and make that great impact.
Great. And can you talk to the age issue and the isolation, and what are you seeing in Texas?
Yeah, it's interesting, and I really appreciate the question. The Surgeon General has come out and identified loneliness as a real public health crisis that we need to pay attention to. EHF had the opportunity to partner with colleagues at the University of Texas on a social determinants of health intervention that I think is unique, and also shed some light on ways that we can address some of the social isolation that the elderly experience. And so the program was intended actually to support Meals on Wheels engagement, so food being delivered to different elderly members of the community. And certainly those touch points of delivering food allowed individuals to make human contact with the people who were doing the delivering. In follow-up, those individuals then called to check on the elderly community member just to see how things were going. Nothing specific, no specific agenda, just to check in on them. And part of the research project was to identify and categorize symptoms of depression in individuals, and they found a remarkable reduction in depressive symptoms in those individuals who received the follow-up phone call just to check on them. So when I think about low-hanging fruit that can get at addressing social isolation, it's interventions like that. And they don't have to be from, research institutions. These can be community organizations, they can be congregations that make it a point of reaching out and just allowing for that social connection and social cohesion with some of the elderly folks who may not be able to get out and about as much.
Well, that's what I was thinking as you said that. If people who are participating in this event today are thinking, what can I do? There's one easy thing, right?
Absolutely.
Terrific. Well, I have another question for the two of you, and that is that the research has shown, I guess you can validate this for us, but that people of color often have weaker social determinants of health, and that those lead to inferior health outcomes. So can you comment on that, and any thoughts on steps that can be or are being taken to address those disparities?
Yeah. So go ahead, Ann. I'll let you attack that first.
Yeah, I'll kick it off and then please join. There's really interesting research that looks at zip code and life expectancy. And I actually attended a meeting a little earlier today, and in Texas, the life expectancy in some zip codes is 56 years of age, as compared to other zip codes where it's 97 years of age. And if you look in those zip codes, you will begin to see what is impacting life expectancy. So levels of poverty, access to food, employment levels, educational attainment levels. And so we know that those poor health outcomes are highly linked to those social and non-medical drivers of health in the environment that we discussed at the start of our time today. So I think acknowledging that those factors impact health is the first step. And then the next is, how do we begin to create interventions that buffer individuals from some of those social needs that we identify. These are big, wicked problems to address. And I think that there are some policy changes that could help address some of those social needs. But then there are also some on the ground community ways in which we can address some of those needs as well.
Right. Well, that suggests that looking at average life expectancy in the United States doesn't tell us a lot based on what shared. Wow.
I loved what Ann just said in terms of the disparities issue. It is amazing to look back at the history of what we know about disparities in health outcomes. And believe it or not, the first time we identified it as a serious national problem was in the civil rights laws of the 1960s. Written into those laws, most people don't realize this, are statutes around defining that a disparate health outcome is a violation of one's civil rights if you suffer from that. And the Justice Department is actually tasked with enforcing that rule. Tragically, it has not been enforced very much. We suffer from terrible disparate outcomes in communities based on zip codes, based on which side of the railroad tracks you might live on, where one side or the other side of the river. I remember being in a meeting at the AMA Commission on Health Disparities, and I was a speaker and I was waiting to speak, and the person before me presented data that was just astonishing, where they removed every other variable from the equation about what could lead to a person having a disparate health outcome except one. And that one variable that was not removed was which side of the railroad tracks in cities where they could isolate it, the person lived on. And it was the strongest by odds ratio predictor of a disparate outcome, a poor outcome, was that, not what doctors you got to go to. It was just amazing, took out every other variable. Disparities are critical, they exist, we have to address them. One thing we're trying to do among many, but the thing we do first when we target a community where we want to build infrastructure for excellent healthcare providers to address these social determinants is we basically look for areas, neighborhoods, communities that are ethnically and racially diverse, lower to median socioeconomic status, and in a zone that's been designated as either a health provider shortage area or a medically underserved area, 2 designations by federal and state agencies. So we target the right location and the lack of access existing already.
One of the other things that I think is interesting as we are on the other side of COVID is that public health was really prime time for the country. And I think it really shed a light on how at risk certain populations are, so poor populations, communities of color, how much more at risk for severe illness certain populations were. And I think for maybe the first time for a lot of Americans, they appreciated that it's not just access to healthcare. There are a whole host of things that stack the cards against certain populations when it comes to their health. So we have a lot of work to do, but I think more and more people understand the differences that exist now.
Thank you. Well, both of you are bringing tremendous amount of financial resources to address this problem, but 2 very different types of organizations. And you lead a philanthropic organization. Len, you lead an organization that is attempting to make money for your investors, including the Church Pension Fund. And I thought maybe I'd turn to Christopher to just talk about how how we think about kind of sources of capital and some of these, areas of socially responsible investing.
Well, I'm glad to comment on the spectrum of capital sources and recognizing that in this particular discussion, we are focused on social determinants of health and how do we address those issues very, very directly. But if you think about the socially responsible investing landscape, you have anyone from purely sort of return-seeking investors to pure philanthropic investors or providers of philanthropic capital. And then there are institutions and individuals in between, like the Church Pension Fund. That is, while it's return-seeking, it's also very much values-oriented. And all different types of capital are needed to address the societal problems that we're trying to address. And there are roles to play for different types of capital. The one thing I will say about return-seeking capital that is important, actually two things about return-seeking capital. One is, if you want to scale to address a problem, scale is usually amplified if you do generate returns for the capital that's involved. So if there is a problem that you're trying to solve, let's use climate, for example. If you're trying to identify climate solutions and the climate solution generates a strong return on investment, more capital will flow toward that climate solution, thereby getting the scale that you're needing to address the problems you're trying to solve. Second issue is around pace. That is, as a general rule, institutional investors are impatient. They want results and they want it quickly. Well, if you're putting capital to work, you're more likely to solve a problem quickly if you have return-seeking capital that's after that. That said, return-seeking capital can't solve every problem. So there are times when you need concessionary capital, times when you need outright grants. And that's why the work of Dr. Barnes and her organization is so irreplaceable in this whole spectrum of where we're working together to try to solve problems.
Thank you. Well, I saw that somebody in the chat, I'm going to ask Dr. Barnes and Dr. Frommer to kind of put on their physician's hat, because someone in the chat said, I'm a physician too, and how do I start incorporating these concepts of social determinants of health in my own practice? So what would you each advise?
I would say the first step is to ask the questions. So we found in a lot of our clinics that we were supporting that they weren't asking about issues outside of just sort of typical clinical medical questions. And so understanding what people are experiencing in their lives outside of the clinical setting, I think, is a great first step. And then that allows you to identify community partners that you may want to connect with that can help individuals address those social needs. So I'd say that's probably the first thing to do. Ask questions. There are a lot of tools out there that give you guidance on what domains to ask questions about: food, housing, employment, transportation. And then you can find other organizations in the community that can help you address those needs.
Yeah, there'd be a set of questions that would get you to kind of, this child has a very old mattress, or, mold in the house and such, right?
That's right.
Yeah, kind of nice name for what I think Ann just described is, how do we do better whole person care? Mm-hmm. And if we're a primary care practitioner and taking care of patients in a community setting, how can I, outside of that exam room, make a difference for the patient who I know needs more than just addressing the biologic determinants of their outcome? One great example, we have something out here that was called the Medical Leadership Council, that in an age before we had a lot of real strong internet kind of database communication and solutions, we put together a real kind of old-fashioned directory of the partner neighborhood organizations that doctors and healthcare teams could lean on to partner with to address things like food deserts, healthy lifestyles, transportation issues. And it was essentially a reference database for who do you call when you need those kinds of things to do whole person advanced primary care and address the needs, the social determinant needs for the patient. Examples like that, how do you get started, is to really kind of work outside of your four walls, if you will, to try and nurture, build, and partner with those organizations like that.
In my experience, especially speaking with our investment team and such over the years, it seems that, for instance, the focus on the environment was kind of, off to the side, a little bit edgy and such, maybe 10 years ago, even, little, maybe 5 years ago, but so central now to how investors and philanthropies are thinking about climate change. And I'd like to understand from each of you how you see the kind of trends and history of focusing on these social determinants of health. Are we seeing the interest? You've both given very, very exciting and encouraging examples of the work that you're doing. Is this something that's snowballing and becoming much more mainstream? And over what period of time have you seen that shift, if that's the case?
Yeah, so wonderful question, Mary Kate. The arc of change takes a long time. It's long, it's large, but it's moving. In social determinants and addressing them and moving the needle in terms of outcomes in our system, it's happening. It's a bandwagon. People are getting on it for sure. It's taken a long time for those of us who worked in it for a long time back. I remember starting with safety net populations and care in the Medicaid program back in the 1980s, and how there was such strict handcuffs on what we were allowed to use Medicaid money for to take care of folks. It was strictly, you can pay a lot of money and Medicaid would cover this very expensive medication. But if the true root of the patient's problem was food insecurity, not a penny of it could be used to address that. And moving from that to where we are now, I think it's a great example in answering your question of what's happening. Every Medicaid program in the country has already started or is looking at getting waivers from the federal government that are needed to say to the federal part of the Medicaid dollars, we want to do something different here in our state. Here's what we want to do. Can we get a waiver from the existing statute and regulatory rules in Medicaid on a federal level to be able to address the social determinants? Things like stable housing, food insecurity, transportation. To go back to the asthma story that Ann was talking about at the beginning, respiratory patients who need an air conditioner or address the mold in their housing, to have Medicaid somehow figure out how that can be a part of the solution, the Medicaid dollars. California has started something called CalAIM, AIM, which is a huge rethinking through a waiver from the federal government of how do we take Medicaid dollars and provide for addressing the social determinants. There's a lot of other states lined up right behind us doing exactly the same thing. And for the physician who asks, how do I get started in doing this? Both the Medicaid money and commercial insurance programs are making that available as a covered benefit solution for the right patient at the right time to address that whole patient care of social determinants.
Very positive. And what have you seen? What's your observation?
It's definitely a long game to get people to think like we think. And Episcopal Health Foundation 6 years ago started a relationship with our Medicaid, state level Medicaid agency, and then also managed care organizations that administer Medicaid, and started really talking about these social determinants of health and how important it would be to address those to really improve health. And this spring, Medicaid in Texas released an action plan to focus on housing, transportation, and food as non-medical factors that impact health. And what will then follow is creating mechanisms to use monies, Medicaid monies, just as Lynn said, to begin to address some of those needs. So I think that the train is moving down the tracks and in the right direction, and that there really is a snowballing effect of people recognizing the importance of addressing these needs.
Great. Well, we're running out of time. And so I'm going to ask one last question. There were a number of questions about housing that our audience asked, and you've both mentioned it in different contexts, but Anne and then Len, do you just want to say a few words about the impact of housing on health? And we've heard about mold and carpets and all, but kind of housing basically on as a factor in health, and perhaps some inspiring, hopeful words as to what's going on in that area. So, Anne, quickly, well, this will be a little bit of a, kind of one of those kind of bullet things because we only have a couple of minutes here, but give us a short answer on that, please.
I would say that if you can't be secure in your housing, then you can't put a whole lot of energy in managing any other part of your life. And so housing is a critical social determinant of health. I'm glad that in Texas we recognize that, and we're going to start putting some structure around helping people ensure that they have stable housing. And I'm going to kick it over to Lynn because I know this is a huge part of what he and the trust do.
Yeah, thank you, Ann. Great question. I can say ditto to what Ann just said, and also that we don't get to sentence number 2 with any of our healthcare providers that we build facilities for without them bringing up, can you guys do housing for us also? It is ubiquitous. It is a huge fundamental problem. We address it with our housing fund. We own and operate housing facilities across the country that are kept at rate affordable. We do it through a unique model, but the bottom line is we see it as a big problem. We work with our housing fund and other housing agencies. Imagine having the PACE Center I described for frail elderly at the bottom of a 6-story building for seniors to live in that they can afford and have stable housing. And they go downstairs to the PACE Center, which is located on the first floor for the services that the PACE teams can provide. That is heaven for developers and our clinical partners to think about when they can achieve that. It's a beautiful model.
Thank you. Well, we started off this conversation describing a really daunting problem, and it is truly daunting. The figures, the statistics are not great. And yet I'm coming away from this conversation incredibly inspired and incredibly optimistic by the work that you each do. So I hope that all the others who are listening in to this program today are coming away also inspired. And we've also had some tips of how there are things that we can do, simple things like calling people and checking in on them that, everybody can do to help improve health. So thank you both. This was a great conversation. I'm grateful for all the work that you both do and just so pleased that you were able to join us today. Thank you. Thank you.